All right, good afternoon, everyone. Welcome to the VCU Department of Internal Medicine Grand Rounds. Today is June 2nd, 2022. I'm Christian Bergman, the Medical Director for Grand Rounds. So before we get started with today's speaker, just want to thank everybody for filling out the survey and provide some feedback for next year. Today is the second to last Grand Rounds for this season. We will have the last one next week, and then we'll take a pause until end of August, early September. So stay tuned for more communications around next season. Today, you'll be able to use the Q&A function, the chat, or you can unmute yourself if you want to ask questions towards the end. We will help facilitate a Q&A with our speaker. The session will be recorded, and the CME information and the code should be in the chat box. We'll put it in now and then at the end of the session as well for folks to receive credit for today's talk. So today's session is sponsored by the Division of Hematology, Oncology, and Palliative Care. Our speaker today is Dr. Renato Martins. He's the professor and chair of the Division of Hematology, Oncology, and Palliative Care here at VCU in Richmond. The title is Lung Cancer, 25 Years Later. So I'm going to turn it over to our department chair to introduce Dr. Martins, Dr. Patricia Syme. Thank you so much.
Good afternoon, everyone. And it really does give me enormous pleasure to introduce Dr. Renato Martins. So I'm sure many of you have already had the pleasure of meeting Renato. He arrived March 1st and it's already made in 3 very short months incredible progress and very impactful, I think, for our patient care. Is going to be a tremendous colleague for us going forward. And we're just thrilled that you're here and excited to formally welcome you because I think this may be your first formal presentation. So for those of you who don't know Dr. Martins, he is a native of Brazil, actually did his medical training there and has his medical degree from Rio de Janeiro in 1992. And then traveled, across the pond and received a master's degree in public health from the Harvard Chan School of Public Health, and completed his residency and then a fellowship in hematology and oncology at the Mass General in Boston. Now, when he finished his residency and fellowship training, he went back to his native Brazil and became the chief of medical oncology at the Brazilian National Cancer Institute and did an amazing job over the years of growing that program to over 800 patients from a very small footprint. It was actually really remarkable because at that time, Dr. Martins was, much more junior in his career. So that was really impactful. He returned to the US in 2004 and traveled to Seattle to the Fred Hutchinson, where he rose up through the ranks, becoming an endowed full professor. He was there for 18 years and really grew their head, neck, and lung cancer program. It really has been very pivotal in some of the important clinical trials in non-small cell lung cancer from early phase through to phase 3, and has worked extensively with industry, published and presented nationally. And I think it's just a tremendous addition to our team here. Lung cancer remains a huge problem for us all, of course. So really, Renato's going to bring his energy and enthusiasm, which is boundless, to our wonderful oncology and palliative care division. And we're excited what he's going to bring to the future, not just in administration, but his care for patients. He's already busy in the clinic. And it was no surprise he was a top doctor multiple times in Seattle. So we're throwing down the gauntlet for the future here in Richmond. He's been very well supported by not just the industry, but also the NIH, and I think will bring lots of new opportunities to us. Now, it's always good to know a little bit about folks outside of work. So Dr. Martins says he's a good squash player, and we're going to test that theory. And he's an avid cyclist. So if anyone is interested in joining a cycle around Richmond, I think he can already give you a tour. So Renato, we are just thrilled to have you here. And before I hand over the reins, I want to say an important thank you to Dr. Khalid Mateen, who served in the Division of Hematology, Oncology, and Palliative before we recruited Dr. Martins. Khalid is a wonderful colleague, a tremendous oncologist, and really did a terrific job. So I really want to express publicly my thanks to Dr. Mateen for his role. And with that, I will hand it over. Thank you.
Yeah, thank you for this incredibly kind and humbling introduction. This is my debutante ball here at VCU. And I think I have the appropriate amount of excitement and nervousness attached to this presentation. I wish we could all be in the same room so I could see if people are taking a nap or actually engaged. But I'm gonna do my very best to try to make this as informative and at the same time entertaining. So next year, I will complete 25 years of finishing my fellowship in hematology and oncology. I had an interest in lung cancer during my fellowship. And it's really amazing how much the landscape of lung cancer has changed over these 25 years. So I have no conflict of interest in this talk. And this data is a little bit old, but I think it's important to always remind ourselves that lung cancer still kills more than colorectal, pancreatic cancer, and breast cancer combined. And in fact, if never smokers with lung cancer was a separate disease, it would still be in the top 6 most lethal cancers that we have. And that is something that is really astonishing of how big of a problem lung cancer is. So the 1990s brought us worse music because there was no better music than the 1980s. Better fashion, which was a low bar because the fashion in the 80s was atrocious, but also brought us some new chemotherapy agents, paclitaxel, gemcitabine, and docetaxel. And of course, this doesn't matter for this audience, and I'm not going to go over and over, multiple names of chemotherapies. But there was a lot of hope that these conventional chemotherapy agents would bring better survival in comparison with the 7 to 8 months that we had in the 1980s. The old trials that compared chemotherapy with best supportive care had median survival for best supportive care between 3 and 5 months, and survival with chemotherapy between 7 and 8 months. So again, between 3 to 4 months in median survival with the use of palliative chemotherapy. And at that time, pretty much all you needed to know was if someone had non-small cell lung cancer or if they had small cell lung cancer, and that was pretty much it. And chemotherapy for both were actually similar and had a median survival in both cases that was less than a year with no known benefit of screening. So because of these new chemotherapy agents, there was a lot of enthusiasm that we were going to move the needle forward in terms of the survival of patients with lung cancer. And then on the ASCO of 2000, which was in New Orleans, it was one of the plenary, and ASCO is the meeting of the American Society of Clinical Oncology, which is kind of the international meeting for oncology. It's actually starting tomorrow in Chicago. And in the old days before pandemic, about 45,000 people from all over the world came to this meeting. And on ASCO 2000, ECOG, one of our former national cooperative groups, presented this study that compare different chemotherapy agents, paclitaxel, gemcitabine, and docetaxel, and a fourth arm that was paclitaxel with a different doublet, to try to establish which of these regimens was going to be the standard of care going forward in lung cancer. Each one of these agents belonged to a different drug company. And as you can imagine, there were billions of dollars hanging on this one presentation. If gemcitabine, for example, or docetaxel were to come ahead, it would become the new international standard of care for lung cancer. And the investigators from ECOG really did a terrific job not disclosing any hints that I was aware of or that anyone I know was aware of of which arm was going to come ahead. And that's the result of the trial. And you may say, oh, this is a pretty small curve. I can't see which arm came ahead. And the reason we can't is because none of them came ahead. And in the New England Journal of Medicine publication, we just decided to go ahead and put all of them in black because it really doesn't make any difference. And the median survival for the entire cohort was 7.8 months, which was exactly the same as what we got in the 1980s. And as a consequence of that, there was a very timely editorial that accompanied this trial when it was published in the New England Journal of Medicine, saying that it was time to move on from chemotherapy. And I could not agree more at the time that really variations of chemotherapy were never going to be the answer for this problem. So coincidentally, around the same time, we start getting these reports that patients with advanced lung cancer, sometimes after multiple lines of therapy and enrolled in a phase 1 clinical trial, were being treated with EGFR inhibitors given orally, tyrosine kinase inhibitors of EGFR, and they were having very rapid, substantial improvement of their cancer. The first one to be developed was gefitinib, and this drug belongs to AstraZeneca, who also had tamoxifen. And at the time, the line in 2001 was that this drug gefitinib would be the tamoxifen of solid tumors. Of course, breast cancer is a solid tumor as well, but it would be broadly used in different solid tumors. And this was the fastest jump from phase 1 to randomized phase 3 trials. There were close to 6,000 patients that were enrolled in clinical trials of combining these agents with chemotherapy. These were not supported by any phase 2 data that suggested that this combination was going to be superior. And what all these trials show was that the addition of an EGFR inhibitor to chemotherapy in the first-line setting made absolutely no difference whatsoever. So that was incredibly disappointing. Interestingly, investigators from Canada took a different approach, and I was the PI of this trial at the Brazilian National Cancer Institute, and we published this at the New England Journal of Medicine in 2005. This was a very pragmatic study where patients that had received at least one prior line of therapy were randomized to receive erlotinib, a different tyrosine kinase EGFR inhibitor, or placebo. And in fact, you could follow the patients with chest x-rays if you wanted to, because all they wanted to know is, do people live longer or not with this strategy? And as you can see here, there was an absolute gain of 2 months in the median survival with the use of this agent. And that was, in fact, the first full FDA approval of a EGFR tyrosine kinase inhibitor in the US for the second and third line therapy of patients with non-small cell lung cancer who had progressed after prior therapies. But of course, this is very marginal benefit of treatment. And in 2004, we finally discovered why some patients had the benefit you saw in that prior CT scan, where the tumor seemed to kind of melt away. And that's because about 10% of patients with lung cancer have activating mutations on the tyrosine kinase domain of the EGFR. the two most common ones being the L858R and the exon 19 deletion. And when these activating mutations are present, the tumors are much, much more sensitive to oral tyrosine kinase inhibitors of EGFR. I was one of the authors of the first trial of EGFR targeted therapy for patients with an EGFR mutation, but the trial that really changed the landscape of first-line therapy of lung cancer was this trial done in Asia, where they randomized patients to receive gefitinib, that EGFR inhibitor from AstraZeneca that I mentioned before, or chemotherapy with carboplatin and paclitaxel. And the inclusion criteria of this study back then was that patients had to have a no or light smoking history. Not all patients had an EGFR mutation, but they collected tissue in all of them. So they had the data for those that had an EGFR mutation. And as you can see here, for patients that had an EGFR mutation positive tumor, the use of gefitinib, an oral tyrosine kinase inhibitor, was far superior, decreasing the chance of progression by slightly over 50%. Obviously, what this showed as well is that the treatment with gefitinib was much better tolerated than conventional chemotherapy. If you're not familiar with these agents, the main side effects are a rash that looks like an acne type of rash and some diarrhea, and those are manageable. It's very rare that patients have to discontinue therapy because of these toxicities. So this trial established, and others have confirmed the exact same data, that for patients that have an EGFR mutation positive tumor, the standard of care is the administration of first-line oral tyrosine kinase inhibitor. So this is a trial that was published in the New England Journal of Medicine in 2020, now using a third-generation EGFR inhibitor called osimertinib. As you know, during the 1970s, 80s, and 90s, the way we designed drugs was by, quote unquote, finding compounds. And we don't do that anymore. Now we develop compounds that will target the tyrosine kinase we need with the highest possible specificity for that tyrosine kinase inhibitor, and we can even manipulate that molecule to make sure that has good brain penetrance. And that's exactly what osimertinib is. It's a drug that was designed to overcome the most common mutation of that confers resistance to EGFR TKIs or tyrosine kinase inhibitors, and has a better brain penetrance as well. And as you can see here, there was again about 50% improvement in time to progression or decreased risk of progression with the use of I'm sorry, a 20% improvement over the 50% improvement that you had with the first generation agents. And as you can see here, if you draw a line on the 50% mark, you have a median time to progression that is above 3 years, which is very, very impressive. So EGFR kind of opened the gates of therapies that can be molecular targeted in lung cancer. And then the second one was ALK. And here I'm accelerating the story a little bit. The first drug that was approved for ALK was crizotinib. And unfortunately, the FDA at the time, the FDA has evolved, but the FDA at the time gave a preliminary approval of crizotinib with the condition that there would be randomized trials versus chemotherapy, which is, in my opinion, completely unnecessary and a waste of patients' time and effort. Because if you have the right target and you have consistent results that showed outcomes that are far better than you would expect with chemotherapy, obviously one needs to question what's the need for a randomized phase 3 trial. This is a randomized phase 3 trial, but comparing two different TKIs targeting an ALK translocation, which was again the second of the activating mutations in lung cancer. And as you can see here, this drug is also designed to overcome some resistance of crizotinib and has much better brain penetrance as well. And this is progression-free survival. And if you draw a line here out of the 50% mark, at 30 months, you have not reached the median yet. The median seems to be around 36 to 38 months. And that's an incredibly impressive result. I mean, let's remind ourselves that in the beginning of this talk, I explained to you that the median survival of lung cancer was 7 to 8 months. And now we're talking about time to progression, that it's about 3 years. The third of the molecular targets in lung cancer to be identified was ROS1. This one was approved based on a phase 1 clinical trial of crizotinib, which is published on the New England Journal of Medicine. And as you can see here, this is what's called a waterfall plot, where each column represents the amount of tumor shrinkage that a patient has with this agent. And as you can see here, the vast majority of patients have substantial tumor shrinkage with these agents. And here is a PET scan where a patient has multiple lung and mediastinal lesions, liver lesions as well. And this is a PET scan 7 weeks later, where you have a complete metabolic response to this agent. We actually published this study. I'm not the author. We had a person that was dedicated to tyrosine kinase inhibitors back in Seattle, and she's the author of this trial combining a BRAF inhibitor and a MEK inhibitor, which led to FDA approval of this combination for tumors that have a BRAF V600E mutation. This showed a 64% response rate, which is about 2 to 3 times higher than you would expect with chemotherapy. And you have a median progression-free survival that approaches a year. So again, that's one example that if you have the right target and the right drugs, you don't really need randomized data comparing with chemotherapy. It's like I need to pick up the pace a little bit. So this is Amtrak. This was also, I'm going to the approvals in chronological order. This is the first targeted therapy that had FDA approval being disease inspecific. So what you can see here is that you have a number of different solid tumors that may have an NTRK mutation. And it's very rare. It's probably less than 1% in lung cancer. But if an NTRK mutation is present, these patients also have a very profound response, a lot of tumor shrinkage that is also sustained. So this was the first approval by the FDA of a tyrosine kinase inhibitor that was molecular defined, but not disease specific. So this is targeting RET. This is a fusion mutation, and fusion mutations may not be as easy to be detected with DNA-only analysis, and they may require RNA analysis as well. And this is a trial published at the New England Journal of Medicine, where patients that had this RAT fusion in non-small cell lung cancer, fairly large phase 2 trial, received therapy with the sapercatinib, which is a RAT inhibitor, extremely well tolerated, has very few toxicities. Patients could have received prior therapy or be untreated. And among those that had received prior chemotherapy, the response rate was 64%. In the second-line trial, chemotherapy probably has a response rate of about 10%. And for patients that had not received any prior therapy, the response rate was 85%. And the median duration of response was 17.5 months. Again, this is duration of response, not survival. And as I said, the treatment is extremely well tolerated, with only 2% of patients discontinuing treatment because of drug toxicity. So HER2, there has been a resurgence of antibody drug conjugates in oncology. There was a lot of research on that area in the 1990s, mostly around lymphoma therapy and solid tumors that got abandoned and got resurrected through the avenue of breast cancer. So this is a drug that combines trastuzumab against HER2 and a topoisomerase 1 inhibitor payload. And for patients that had HER2 mutation, so this is not HER2 overexpression as you see in breast cancer. This is HER2 mutation that activates the receptor. They observed a response rate of 55% and a duration of response of 9 months and a median progression-free survival of 2 months and an overall survival of 17.8 months, but this is heavily pretreated patients as well. So KRAS is the most common mutation in solid tumors, and you have multiple different KRAS mutations that are all activating. And in lung cancer, the most common one is the G12C mutation. It's described as in 13% of lung adenocarcinomas. That's certainly not what I see in my practice, but it is probably the first time that we actually were able to break into KRAS with an effective therapy. So this is a trial that was published last year on the New England Journal of Medicine, where 126 patients, the vast majority having received prior chemo and immunotherapy, were treated in this phase 2 clinical trial with sotorasib, which is a KRAS inhibitor that is specific for G12C mutation, does not work for other KRAS mutations. Approximately 20% of patients had more significant toxicity. This drug is not as well tolerated as other tyrosine kinase inhibitors that I have been discussing with you. And the main side effects are fatigue and some joint pains. This is again one of these waterfall plots where you can see the amount of tumor shrinkage from each patient that is represented in each one of these columns. And again, with this heavily pretreated population, the median overall survival was 12.5 months, with some patients achieving more prolonged survival. This drug is not as active as other tyrosine kinase inhibitors that have a molecular target, but I think the importance of it is that it's now FDA approved and it's the first target that we have for KRAS. And then we have a MET exon 14 splicing mutation or MET amplification. These drugs actually work in both scenarios. The degree of amplification has to be quite high, probably around 10 copies of the gene or higher. MET exon 14 splicing mutation or high degree of amplification is present in between 3 to 4% of non-small cell lung cancer cases. And the most common side effect is the development of peripheral edema. And as you can see here, in patients that have a very high degree of amplification, the vast majority of patients had substantial tumor shrinkage. And that is even more impressive when the exon 14 splicing mutation is present. And that, again, led to the approval of capmatinib for this indication. There are actually other drugs that are approved for the different indications. And if you want to count, you have 1, 2, 3, 4, 5, 6, 7, 8, 9 different molecular targets in lung cancer for which we have treatments that are specific for that molecular alteration. And that's why the concept of lung cancer has ceased to exist. There is no such a thing as lung cancer anymore. There is lung cancer with a specific mutation. And until we know what that is, it's very hard to come up with any treatment recommendation. I'm going to pick up the pace and talk about immunotherapy. As you know, immunotherapy started with the development of checkpoint inhibitors. As I explained to patients, checkpoint inhibitors are molecules that slow down the immune system response to the presence of the tumor. And we published this article in June of 2012, which was the first, actually back-to-back articles on the New England Journal of Medicine, and were the first articles that shown a activity of immunotherapy for lung cancer. This is one of the patients that was in this trial. This is her enrollment CT scan. It shows a large right hilar mass, a mass in the left adrenal gland as well. And this is the follow-up CT scan showing complete resolution of both. And that scan is over 3 years later. In 2015, this patient also completed a 100-mile fundraiser bike ride for the Fred Hutch called Obliteride. And since then, she has retired and moved to Arizona, where she plays golf every day. And she ended the trial in the end of 2012. So this year, around November, she will complete 10 years of no therapy whatsoever for her lung cancer. So Keynote-024 was a trial of a PD-1 inhibitor called pembrolizumab for patients that had the PD-L1 expression greater than 50%. PD-L1 obviously being the other X of the PD-1, PD-L1 pathway. It's a poor biomarker for the effectiveness of these agents, but it is a biomarker, and patients that have a PD-L1 expression of 50% seem to have a higher benefit from these agents. So these were a first-line randomized trial in 305 patients with the primary objective of progression-free survival. This trial had a very high crossover rate. So 106 patients that discontinued chemotherapy, among those, 66 crossover to pembrolizumab. So a crossover rate of greater than 60%, which should decrease the survival impact of the medication, because obviously if people that progress in one arm are then allowed to switch to the other arm, they are likely to have benefit as well. And despite that, there was a 40% improvement in overall survival with the use of immunotherapy as first line for patients that have tumors with a PD-L1 expression greater than 50%. And this was obviously revolutionary. And now not only we need to have the molecular profiling information, we also need to have PD-L1 information to determine what's the best treatment for patients with non-small cell lung cancer. And the follow-up of that was, well, if that's better, what about if we give both chemotherapy and immunotherapy? And I tell the trainees that in medicine, you can pretty much explain whatever you want. One could intuitively say, why would you possibly want to combine immune suppressive chemotherapy with immunotherapy? And then when you are faced with positive results, you go like, oh, of course, it's because you're destroying the cells with chemotherapy. So that creates an immune response with a lot of antigen that is being presented to the immune system. And that's why immunotherapy works better. But is that really true? Does immunotherapy and chemotherapy are better than chemotherapy alone? And this trial showed that that's absolutely the case. So for patients that have a PD-L1 expression greater than 50%, the two possible standards of care are immunotherapy alone or immunotherapy combined with chemotherapy. And I make that decision based on the fact that if I think that there is a closing window of opportunity to give chemotherapy, then I would give all the treatment I can up front. But if I don't think that there is a closing window of opportunity, then I will treat these patients with immunotherapy alone. But aside from those, everyone else would be a candidate for chemoimmunotherapy. These are the survival curves. This is people that have a PD-L1 tumor proportion score that is less than 1%. So those are the PD-L1 negative patients. They had a survival benefit. This is for patients that have between 1 and 49%. They had a survival benefit. And those are the patients that had PD-L1 expression greater than 50%, and they also had a benefit. And so that we can be broad, this other drug, atezolizumab, which is a PD-L1 inhibitor, also improves the outcome when combined with first-line chemotherapy, in this case, also using a vascular endothelial growth factor inhibitor. So you may have seen advertised on TV the combination of two immunotherapy drugs, nivolumab and ipilimumab. And this is based on this trial that was published in the New England Journal of Medicine 2019, where the combination of nivolumab and ipilimumab was compared with chemotherapy for patients that had a PD-L1 expression of 1% or more. And it showed that the combination immunotherapy was better than chemotherapy alone. Evidently, one of the problems here is that chemotherapy alone is not the standard of care anymore. So it's unclear if nivolumab plus ipilimumab is a better combination than chemotherapy and immunotherapy for these patients. And the details of how to make that decision is beyond the scope of this talk. But the bottom line is, how do we increase cure rates? This is all palliative treatment, very important. Patients are living longer, they're living better, but we want to cure people. And the first hints that immunotherapy could cure people was this trial for patients with stage 3 disease that was published in the New England Journal of Medicine, 2017. Patients were treated with conventional chemoradiation therapy, and then they were randomized to receive placebo or durvalumab, a PD-L1 inhibitor. And treatment was actually quite well tolerated. The requirement for using high doses of steroids was 8.8% with durvalumab and 5.1% with placebo. There was a lot of concern that the pneumonitis induced by radiation could get quite a bit worse with immunotherapy. That was not what was seen. That was very good news. And this is as impressive of a curve of progression-free survival you will see in solid tumor oncology. As you can see here, there was a substantial improvement in progression-free survival with the use of immunotherapy for these patients. And it's important to remember that patients with stage 3 disease are treated with a curative intent. So that was the first hint we had that we actually could start curing more patients with these new therapeutic approaches. What about adjuvant therapy? So this is also a trial published in the New England Journal of Medicine in 2020, where patients that had completely resected lung cancer and had an activating EGFR mutation were randomized to get standard of care, that the adjuvant chemotherapy when appropriate, and the vast majority did receive that. And then they were randomized to receive osimertinib or placebo for 3 years. And the gold standard for adjuvant treatment is overall survival. We don't have data on overall survival yet, but we do have data on the progression-free survival. And there was an 80% decrease in the risk of recurrence with the use of 3 years of osimertinib. A lot of discussion, and we can cover that during the question and answer. If we are just moving the goalpost into the future, or if we're really curing these patients. That again is something that I don't plan to cover. And that led to the FDA approval in 2020. Adjuvant immunotherapy, this is a trial that was presented last year and then was subsequently published on Lancet. It's 1,000 patients with stage 1B to 3A. After complete surgical resection and adjuvant chemotherapy when appropriate, they were randomized to receive atezolizumab for 1 year or no further therapy. This had a hierarchical testing. So first they tested the outcome of patients that had stage 2 and 3A with a positive PD-L1 expression. If that were positive, then they would test for all patients with stage 2 and 3A. And if that were positive, they would then test for all patients. So that would bring the 1B patients into the fold as well. The progression of the treatment was well tolerated. Only 11% of patients developed more significant grades 3 and 4 toxicities. But the progression-free survival hazard ratio for group 1, so those are patients with stage 2 and 3A with positive PD-L1 expression, was 0.66. So a 34% decrease in the risk of recurrence with a p-value of 0.004. For group 2, this was 0.79 with a p-value of 0.02. And for group 3, now incorporating everybody in an intention to treat analysis, was 0.04 with the hazard ratio of 0.81. So when you look at these hazard ratios, you immediately think, is this really beneficial for these other groups? Or this is all being driven by the group that benefits the most? And as you incorporate groups that have no benefit, you just dilute that benefit. And that's exactly what probably is happening here. Reason why the FDA approved this therapy only for group 1. So those are patients that had stage 2 and 3A with a positive PD-L1 expression. So screening, that's another way that we save lives. This is the data from the National Lung Screening Trial. More than 53,000 patients between ages 55 and 74, randomized to yearly CT scans times 3 or a chest X-ray, with the chest X-ray being the ineffective screening strategy, because it was believed that patients would not want to be randomized to nothing. And we find lots of pulmonary nodules. 39% of patients at one point had a suspicious result. The false negative rate was, the false positive rate was 96%, but there was a 20% reduction in lung cancer mortality, and very impressively, a 6.7 reduction of all-cause mortality. And these results have been confirmed from data from Europe, 15,000 mostly men that were randomized to get a CT at baseline, and then 1 year later, 3 years later, and 5.5 years later, and that showed a 24% decrease in lung cancer mortality as well. So the conclusion from the screening perspective is that lung cancer screening for the appropriate population is absolutely the standard of care. My opinion is that screening should be done and repeated until a finding would not be pursued any longer because of comorbidities. So, you know, the North American trial stopped at 74. Someone that reached 74 now is likely to reach 90. And I would not stop screening at age 74 as long as the patient is in good enough shape to tolerate treatment for a finding of lung cancer. That's an opinion, but it's also the NCCN recommendations regarding screening. And although absolutely no data exists, the risk of a new lung cancer for someone that had lung cancer is about between 1.5% and 2% per year. And in my opinion, these patients should be subjected to screening as well. So the conclusions for this talk is that molecular profiling is the standard of care for lung cancer. Lung cancer is not enough information for management these days. Many patients do not receive chemotherapy for years after their diagnosis of advanced lung cancer, either because they were treated with immunotherapy or one of the TKIs that we reviewed. Adjuvant EGFR therapy and adjuvant immunotherapy decrease the chance of recurrence, but unfortunately, these successes bring a number of new challenges. So there is an issue of cost. Evidently, the cheapest therapy is the one that doesn't work and kills the patient, lets the disease kill the patient quickly. So this all has a very high cost. How do we provide long-term survival care is a challenge. Space in oncology now is a huge challenge because patients remain in the system and they keep coming back to be seen. It was predicted before all these improvements that by 2025, 2030, we would have a crisis of lack of medical oncologists to treat everyone that needs. That has exploded now. APPs are the present and the future of oncology. And how do you bring this highly specialized care to underserved populations? 20, 30 years ago, someone could try to do all kinds of solid tumor therapy, and the amount of knowledge required was relatively small. I think that I probably was able to convey the message that the knowledge in lung cancer specifically has increased exponentially, making a general oncologist someone that is really challenged to keep up with everything that is going on. And one thing that I want to be investing some of my time in the very near future is strategies to bring therapy and highly specialized care to people. This is the National Health Services in Britain that has a mobile infusion unit that brings therapy to the people. And if we think about the use of telehealth, it's possible that they can get treated and see highly specialized oncology providers as well. That is starting to spread here in the US as well. This is perhaps a way we can deliver highly specialized care to our underserved communities around Richmond. This is really the golden age of oncology now. This is a patient that survived 5 years with advanced lung cancer, and she brought me a cake to celebrate that. And this is a patient that survived 10 years with advanced lung cancer. And now I'm obviously have to start counting that again, but I had a number of pictures in Seattle of patients that had completed 10 years of advanced lung cancer. And I demanded, quote unquote, that they brought a cake with 10 years written on it so we could take a picture. And I'm going to conclude by saying that this is a picture of the neighborhood I was born in, Rio. And I'm incredibly happy to be here.
Thank you, Dr. Martins. Wonderful presentation, and agree, a lot has happened in 25 years. I'm sure I know that was just a snapshot of clinical trials. So thank you for walking us through that. I want to go through a couple questions. One that's in our chat box here. What's your take on neoadjuvant therapy with chemo plus or minus immunotherapy in early stage lung cancer? Your thoughts?
Yeah, so the results in terms of response rate and even pathological complete response rates are quite impressive. Everything that has worked in the adjuvant setting works in the neoadjuvant setting as well. I think that what we don't know for sure is what is the duration of these treatments. You know, how much immunotherapy does one really need? The trial that I described with atezolizumab was a year. Okay? What's needed? We need 2 years. We need 6 months. If you do in the neoadjuvant setting and you have a pathological complete response, do you need any more therapy? Or if you eliminated completely the tumor that you could find, didn't you eliminate the tumor you couldn't find, the micrometastatic disease? I think those are questions that will have to be answered. But if something works in the adjuvant setting, it's very likely that we'll have the same impact in the neoadjuvant setting as well.
Thank you. Appreciate it. Any other questions? I have a couple of my mind, but Dr. Syme or anybody else on the, you can ask to unmute yourself if you want to ask live.
So I will ask a question about the lung cancer screening and the gender disparities that have happened with some lung cancer screening. I wonder if you can just sort of comment broadly on that, and then maybe also some other key sort of gender differences in lung cancer therapy. And
yeah, so these EGFR mutations are more common in females and never smokers. So there is clearly, I mean, these are obviously somatic mutations, right? Otherwise we could just do a blood draw and find them out. An EGFR activating mutation is incompatible, I'm told, with normal embryonic development. So you cannot have an activating EGFR mutation and survive embryonic development. But why are they more common in females? Why are they more common in Asian females? There is clearly something on someone's germline that makes them more prone to the development of these activating mutations. And that connection between the germline and the somatic mutations I think it's an incredible opportunity to understand that connection using EGFR mutation as the template for that. Because you can envision a future, there is no point in screening people that are not smokers, right? But you can envision a future where we'll know the germline trait that increases the risk that you will develop a lung cancer associated with an EGFR mutation. And if we get there, then yes, those patients should be screened, depending on what the risk is. As far as the disparity on screening, I mean, that is a huge problem. We don't screen enough, and as I showed in the Nelson trial that was done in Europe, it was predominantly men, and why is that?
An opportunity.
That's right.
Thank you.
I see Dr. Gordon Jinder has a question here. Dr. Jinder, if you want to unmute yourself, please go ahead.
Yeah, can you hear me?
Yes.
So excellent, Renato. That was really, having followed this from some distance, but in oncology for decades, it's really impressive to see it all put together in one presentation. I had a question about the targeted therapy, which I probably know the answer, but I just wondered, in the patients who ultimately fail targeted therapy, has there been any evidence produced that would show a second targetable mutation driving those resistant cancers?
Oh, absolutely. So the lorlatinib, for example, is approved for ALK mutation. It is approved, period. But really, you probably need to have a specific mutation for which lorlatinib was designed for, which is the most common mutation that confers resistance to alectinib, which is the first line for ALK translocation. And I think that what we will see going forward is that companies like Blue and others, there is a plethora of companies now that will design the molecule whichever way they want it, in reverse engineering, so to speak, right? Once you figure out how does the resistant mutation looks like, they can just make a drug for it. And that is really incredible. Yeah, so we definitely have drugs that have been designed for specific resistant mutations, and that's coming with RET as well. Drugs that have been designed to overcome specific resistant mutations.
Great, thanks.
Thank you. I think we have time for one more question. Dr. Stephen Grant wants to ask a question. Dr. Grant, you should be able to unmute yourself now.
Yeah, very nice talk. With regard to resistance to targeted therapies, what percentage of them represent a mutation in the target that doesn't allow it to be inhibited versus activation of a secondary compensatory pathway that can compensate for elimination of the initial pathway, and which might be susceptible to a rational combination approach?
That's right. So the area that this bypass pathway is better understood is MET amplification in the setting of EGFR activating mutation. And it's not yet FDA approved, but I would be absolutely perplexed if it does not become FDA approved to be able to use an antibody against MET in combination with an EGFR to get, because obviously if you have a bypass pathway, you have to continue to inhibit the main pathway. But I think that absolutely the combination of a MET inhibitor and an EGFR inhibitor will be an approved therapy for this disease in the relatively near future. One of the problems is that if you start combining different molecular targets, sometimes you run into significant toxicity, and that combination specifically is associated with can be associated with pretty substantial rash, and that can have a substantial impact on people's quality of life.
Thank you all so much. Thank you, Dr. Martins. Dr. Syme, any closing remarks, thoughts?
No, just a great presentation. Thank you so much for such a comprehensive review of what we've done in 25 years. So an exciting area with lots of, I think, molecular biology driven evidence-based medicine. Fantastic. Thanks.
I love doing it. So
Thank you so much. Your enthusiasm is really contagious, and I think got a lot of people excited here on the call. So thank you so much for excellent talk, and really appreciate it. So Dr. Martins, thanks again for your time, and appreciate everybody's attendance. We'll put the code back into chat box for everybody to get credit. Have a wonderful rest of the day. Remember, last grand rounds of the season next week. Please tune in. Thank you all so much. Have a great day.